Thank you, Dr. Youssef, and it's my pleasure to be here. Thank you for Dr. Hanan and the organizing committee. So my lecture today, how to inject an elbow. Since Dr. Atallah already spoke to you about the anatomy and how to put the probe, so it will be one of the easiest joint that you can have it injected. So can I have the first slide, please? Okay, I have no disclosure for the presentation. Let's talk about ultrasound in general in the musculoskeletal system. The ultrasound guided injection advantages: easy accessibility, repeatability, cheap, and lack of radiation. Real-time assessment as compared to other modalities like the fluoroscopies, CTs, and MRI. The ultrasound guided injection, we already have a hint this morning that it is more accurate than the blind injection, achieve excellent needle visualization, tracking the needle from the moment it enters and enters the skin to the target, ensure that the steroid delivered accurately at the point which we wish to deliver it, like joint, tendon, ganglion cyst, or bursa. Nowadays, patients actually aware about the ultrasound guided injection, and they are aware about that as well. It improves accuracy, outcome, and reduce risk of side effect side effect or injury during the injection. What are the indications of musculoskeletal system injection? Intra-articular, like patients would have acute inflammatory arthritis, osteoarthritis, adhesive capsulitis, and impingement syndromes. The tendon and tendon sheath, acute tendinitis or tendinosis, chronic calcific, non-calcific tendinopathies, persistent tendinopathy, and tenosynovitis. Bursa and ganglion can be injected as well, acute chronic bursitis, periarticular, perimeniscal, and labral ganglion cyst. Preneural, peripheral nerve blocks for acute and chronic pain management, interdigital neuromas, and carpal tunnel syndromes. Intramuscular, acute, subacute, low intermediate grade muscle injuries without tendon avulsion, chronic injuries with focal area of pain, intramuscular hematomas. What you need to know about the procedure of the injection: you have to pick or select your perfect transducer, and we are using the high frequency transducer between up to 15 millihertz. Linear transducer are used for the better visualization of superficial musculoskeletal structures, and this is the one we use for the shoulder. When you have done the shoulder, this is the most popular probe that we are using. Curvilinear, usually it is used for the deep structures like the hip joint because it has low frequency. The hockey sticks, it is high frequency with a small footprint, and it is better or good for smaller joints of the hands and ankle. What do you need before doing the injection? You have to detailed assessment of the area that you want to be injected, or it's the area of interest or target, necessarily to evaluate the pathology and selection technique. Assessment of any vessels or neurovascular bundle in the venicity. Patients should be aware about the procedure, and some of the institute, they needed the patient to be consented actually for the procedure before you doing it. Pre-existing coagulopathies, infection, hypersensitivity reactions are relative contraindications for intervention. You are a physician, so you have to select your patient if they have those problems. The sterility technique is mandatory to prevent any iatrogenic infection, especially in the joint, like the hip joint. You cannot do it in the clinic. It has to be in complete sterile condition. The selection of needle, usually we use the 20-20 gauge needle. This is the more suitable for intra-articular injections or in general for musculoskeletal system. The larger gauge needle can be used if you are going to do aspiration of a fluid like synovitis or hematomas. But the smaller needle, 20 gauge needle, commonly used day-to-day practice. So intra-articular injection, what are the indication or the benefits? They provide short, medium-term relief of painful joint, but do not alter the course of the disease, as you know. This is recommended cases of inflammatory, non-septic, of course, monoarthritis, degenerative joint disease, and adhesive capsulitis. Injection into smaller joint have given better result, as you know, compared to the large joints, like the AC joints, sternoclavicular, carpometacarpal, and subtalar. The technique, we have two techniques actually when you inject a joint, in-plane technique and out-of-plane technique. The in-plane technique is more accurate and long axis of the needle along the long axis of the transducer, as you can see, and then you can see the whole length of the needle from the tip until the area of insertion. And this is more accurate, I said, and you have to select the technique you want to inject the patient within. So this is an injection of the knee, aspiration with the fluid, and this is the in-plane technique. The out-of-plane, you cannot see the needle, but what you can see just the tip of the needle, and this is less accurate, and from my clinical practice, I'll use it very, very occasionally. And the way you are putting the transducer, it will be the transducer of the probe on the long angle, and then you come from the side. That's why you are not able to see the whole length of the needle. You just see the tip of the needle. I'll just give an example how to approach the joint for injection. This is the RC joint, the radiocarpal joint injection. We already visualized the radiocarpal joint in the morning. This is in the longitudinal plane, so you can see the distal radius, the capitate, the lunate, and the capitate. And this is an effusion within the radiocarpal joints. Can I have the video, please? Can I have the video? And you can see that the needle is coming from distal to proximal, and you will inject safely and properly to the target. Another joint in the upper limb is the MCP joint. Again, the MCP joint can be visualized, and then you can inject from proximal to distal, like in this video, from the distal to proximal, or some people, they use it the opposite. I prefer to go this technique, from distal to proximal. Again, this is in plane, that's why you can see the whole length of the needle, and this is the proper way to inject. The elbow joint, we have two approach or two techniques. Either you go posteriorly or anteriorly. So the posterior, you can visualize the olecranian recess or fossa, and there is an hypoechoic collection here which is fluid, and then in your landmark again here the patient will be flexed, arm flexed, or the elbow flexed 90 degree. You just go behind the patient and you're looking into the olecranian. The landmark here, you have the capitulum, and then the trochlea, and this is the olecranian fossa. You put the probe transverse position and your needle again in plane going into the fossa. You inject from lateral to medial. You don't inject the opposite from medial to lateral, because here, what do you have? The ulnar nerve. So you want to avoid injury to the ulnar nerve. The other approach is anterior. An anterior approach, Dr. Atallah, he just mentioned how to visualize the joint anteriorly, and then you have the capitulum here, and the radial head, and the fossa with the fluid collection. And then you will inject. Can you repeat the video, please? Again, you go from distal You go from distal to proximal. Distal to proximal, and not the opposite. You don't go from proximal to distal. What nerve is here? The radial nerve. Okay, so you want to be away again from vessels and nerves. You have to be safe. That's why it is more properly to be inject with ultrasound guided. And last thing, just about few hints about the shoulder injection. Can I have to play the video here? Dr. Youssef already mentioned how to visualize the shoulder joint. This is the spine of the scapula and the acromion, and then you put it just beneath or inferior to the olecranon, and then you will visualize the shoulder joint. Can I have the second video, please? This one. Can you play this video? Once you put the probe properly in the anatomical position, you will be able to recognize 5 important structures. The infraspinatus, glenoid, the glenohumeral joints, humerus, and more distal is the diaphragm. How to inject? We are using, usually for the shoulder, we are using the posterolateral approach. The needle will be directed towards the coracoid process anteromedially. Once, can I have the video here? Once you are in the space, your needle in the proper target, and then you inject. Okay? So to conclude this session, using guided intervention in musculoskeletal disorder is increasing the accuracy of the delivering the therapeutic agent to the proper location and lowers the risk of complication. Local anesthetic and steroid are the most commonly used agents. With the advent of new techniques like the plasma-rich plasma or autologous blood injection has gained some popularity and has provided acceptable results. But from what I'm using in our hospital, steroid and local anesthetic. These procedures are less invasive and can be repeated if required to provide faster healing. As image-guided injections is easy, has better efficacy, and includes much less of post-procedure complication, it should be performed over blind injections in day-to-day practice. So finally, I would like to thank you for listening to my lecture, and remember, musculoskeletal ultrasound guiding you with vision. Thank you very much.